Hi, my name is Anisha Gajas, and I'm gonna talk about Olaparib for metastatic castration-resistant prostate cancer. Definition: Metastatic castration-resistant prostate cancer is when the cancer has spread to parts of the body other than the prostate, and it's able to grow and spread even though drugs or other treatments to lower the amount of male sex hormones are being used to manage the cancer. Olaparib is a type of targeted cancer medicine called a cancer growth blocker.
Olaparib is probably the PARP inhibitor for which we have the most data right now in prostate cancer. It was studied in the 2 PARP-A study by Johan Dubono's group. It was very exciting, published a few years ago, and there's ongoing studies with Olaparib and with combinations with Olaparib. So in that study at least, men were selected to be included in the study as long as they had undergone actually multiple prior therapies and were really sort of treatment refractory at this point. They underwent biopsies before being treated with Olaparib, and then they were followed, and they were assessed for PSA response and for progression. And in this study, for patients who had DNA repair defects, and this was looked at after they were already on the drug, I believe the response rate was around 88%, and response included, was mostly based on PSA response in this study. But that's a really high response rate, very exciting, higher than we would expect in a regular clinical trial, and there wasn't a randomization. This was a single-arm study. Patients who did not have DNA repair defects didn't seem to respond in that way. All of the patients who had BRCA2 mutations did appear to respond. So these were all really exciting things. And so Olaparib in prostate cancer, at least, is pretty far along in its development and its initiation into further clinical trials. And the other PARP inhibitors are on their way, but that's the Olaparib data.
Applications in medicine. Olaparib, a poly-ADP ribose polymerase inhibitor, has shown an improvement in median progression-free survival in selected patients with castration-resistant metastatic prostate cancer. There may be no signs or symptoms at all. Yes, there are mCRPC symptoms, size dependence of the tumors and where the cancer has spread. The signs of mCRPC can start with problems urinating, pain or blood in the urine, feeling more tired or weak than normal, weight loss, difficulty breathing, and bone ache.
When my doctor told me that he could see my prostate cancer had spread to my bones, I was devastated. He called it metastatic. A cancer diagnosis is never easy to hear, but since I was already undergoing treatment, I was hopeful that I would have more time before my cancer showed up in a bone scan or CT scan. I felt like my life was spinning out of control, and I was overwhelmed with the emotional tidal wave I was feeling. At first, I couldn't get beyond the words, "not curable." My mind just stopped, and I was gripped with fear and sadness. Then I decided to get back in the driver's seat of my life and take control of my treatment decisions. Although my cancer isn't curable, I took hope in that there are new treatment options and ongoing clinical trials. These treatments didn't promise a cure, but I could prolong my life, and hopefully a clinical trial might bring a new treatment to market. At this point, it became about my family and feeling well enough to live my daily life. So I told this to my doctor.
There are treatments available for managing metastatic castrate-resistant prostate cancer and more treatments are being researched every day. The goal of treatment is to slow or stabilize the cancer's growth and control symptoms to help you feel better and live longer. Testosterone is the main hormone that fuels the growth of cancer cells. Men who have metastatic castrate-resistant prostate cancer are already on hormone therapy, which lowers testosterone. But your doctor may offer some newer hormone therapies you take as pills that block testosterone in different ways. This therapy uses your body's immune system to fight the cancer. This is often an option for men with few or no symptoms. The most common symptom is pain. In many patients with metastatic castrate-resistant prostate cancer, the cancer has spread to their bones. Some bone-targeted therapies help prevent bone fractures and other bone-related issues that can arise. Other kinds of bone-targeted therapies, drugs called radiopharmaceuticals, give off small amounts of radiation. These drugs can target radiation to the areas where cancer cells are growing in the bones. As with many other cancers, chemotherapy can help slow the cancer's growth and help with pain. This uses high-energy beams to target and shrink individual tumors and can ease pain when the cancer has spread to the bones.
Learning I had metastatic castrate-resistant prostate cancer was a life-changing moment. Although my doctor said he couldn't cure it, I knew I wanted to do what I could to extend my life. But I also wanted to feel good enough to play a few holes of golf or visit with my grandchildren for a good part of that extra time. There are benefits and risks to each treatment. There are also side effects. So I talked to my doctor, and we crafted a treatment plan that focuses on my personal life goals and is helping me enjoy my life and manage the symptoms. Talking to my doctor and deciding on a treatment plan gave me hope. Talk to your doctor about what is right for you.
Pros and cons. Pros. Olaparib was associated with longer progression-free survival and better response measures. Cons. Anemia and nausea are the main toxic effects in patients receiving Olaparib.
For metastatic castration-resistant prostate cancer, when we're sequencing, we have a whole host of options now, which is really great. I remember when I started practicing, I really just had standard castration, a couple androgen receptor drugs like bicalutamide, and then chemotherapy. And we got really creative, but now we have all these choices that are proven to prolong survival, that maintain good quality of life, that reduce skeletal symptomatic events. So it becomes really an opportunity to individualize in the absence of directly comparative data. There's not one right sequence, and so we can look at a patient, and you may have a patient who, after abiraterone or enzalutamide, you might want to give chemotherapy, but they might be elderly, or they might be young and working and can't really afford to quit their job for the 6 months or so that you want to give them chemotherapy. And so we have radium-223 as a nice option in that niche, especially if patients have bone-only disease or metastatic disease limited to the bone. For patients with soft tissue and visceral metastases, that's not an option. But on top of chemotherapy and abiraterone and enzalutamide, there is immunotherapy with sipuleucel T for the right patient who's progressing slowly, minimally symptomatic or asymptomatic. And so it's important to really look at the patient's characteristics, think through what's the pace of their progression, what's the distribution. Imaging becomes key in this context as well. And it's important to remember that sometimes PSA can be going up, but a patient can look and feel great, their scans can be not changing, and we really want to get the most mileage out of the treatment they're on in that situation, and it's probably not appropriate to switch therapy.
Issue applied in Ecuador. It's used in Ecuador as a potent inhibitor of human poly-ADP ribose polymerase PARP1, 2, and 3 enzymes and has been found to inhibit the growth of affected tumor cells line in vitro and tumor growth in vivo, either as monotherapy treatment or in combination with established chemotherapies. It's contraindicated during pregnancy and affects the ability to drive.
I think the key takeaways from the data set is that this is a very heavily pretreated population. I mean, 25% of the patients had received basically everything, abiraterone, enzalutamide, docetaxel, cabazitaxel. So the response rates that we saw were not huge, but they were reasonable considering that population and the fact that this was molecularly unselected and we did not have any confirmed patients with DNA repair alterations. So what we saw were that in the soft tissue disease patients, we saw 14% with a significant PSA decline greater than or equal to 50% that was confirmed, and we saw that in the overall population it was about 12%. I think the most interesting thing is the soft tissue disease RECIST 1.1 analysis, where if you look at the waterfall plots, 29% of the patients who had soft tissue disease had significant shrinkage greater than 30% of their target lesions. The confirmed overall response rate, however, was 7%, but the one thing that I should point out is that RECIST 1.1 is hard to confirm in prostate cancer if you have non-target lesions like bone metastases or bone scans that look worse. And that is what happened in all of the patients that had those responses other than one, is they had progression in non-target lesions and bone lesions. So there are a couple hypotheses there. One is, could that have been healing flare, and that actually those patients were still responding? Because when you give an IO therapy, you usually see a durable response. It's rare to see a short-term response and then progression in the bone somewhere else. So could that have actually been healing in the bone and have been labeled as not being labeled as a confirmed response purely because of a healing flare in the bone? I think one other possibility is the bone microenvironment and soft tissue microenvironments are different, and perhaps this might work better for soft tissue, but I think those sorts of hypotheses need yet to be validated.
Conclusion. Treatment with the PARP inhibitor Olaparib in patients whose prostatic cancers were no longer responding to standard treatments and who had defects in DNA repair genes led to a high response rate.
Well, I think there are a number of challenges. I think it's a new field for us. We have a whole new learning curve on these new therapies, and we have to know how to administer the therapies, know how to take care of adverse events, and be able to make decisions that are going to be most appropriate for patients. So, you know, the learning curve is one. I think trying to integrate it into our practices, I think that what we found, and especially in some of these larger group practices where we can have an advanced prostate cancer clinic, I think that developing that clinic is a challenge. You have to have financial backup. You have to have commitment, really, from the other docs, so that the doctors will refer to a physician champion. And we have to be very knowledgeable in our treatment of these patients. We have to operationalize the entire clinic. We have to make it work. We have to have a nurse navigator. We hired a nurse navigator. So we need to have nurses, nursing navigators, staff. We may need to increase our space in order to be able to have an advanced prostate cancer clinic. And then we have to be able to deal with some of the cost issues and making sure that we're not having problems collecting for certain therapies that we get. So you have to make sure that you're going to, any treatment that you're going to prescribe, that you can be reimbursed for it. So that could be a problem. So these are some of the challenges that we run into. I think operationalizing it is a big issue in our practices.
Thank you for your attention.